So when we started discussing this session, it was what I was asked to do was rather challenging, was to give a rather technical presentation on what is available from a digital perspective, from an interoperability perspective, and what could be achieved in primary care and why it should be achieved in primary care, whilst at the same time to talk a little bit more about what digital tools could potentially offer us in terms of resilience and compassion. So I've tried to put some things together, which is difficult because such topics are better discussed in a group, of course, with physical interaction or face-to-face, if possible. But I will try and send as much material as possible to clarify the project work, which is briefly presented. Let's see. Okay. So I will start, probably you have seen, all of you, in the last few days at least, or in the past couple of years, the Sustainable Development Goals mentioned. I will only focus on SDG 3, particularly SDG 3.8, because that's the universal health coverage sub-goal or objective. And I will say that what we have at the moment, which we never had before, is political commitment from all United Nations member states to contribute towards universal health coverage. And this came out of the UN General Assembly in September. And during that event, which was sort of its thunder was stolen by the parallel same day climate summit, was quite unprecedented, because there was commitment from every member state of the UN to committing resources and reinforcing universal health coverage efforts, including putting primary care at the forefront to achieve universal health coverage. More specifically, for those that do not come from primary care and not primary care researchers, I myself come from oncology. I'm a public health specialist, but I've been researching primary healthcare for the past few years. We have had many decades before the declaration of Alma-Ata, which was putting in a people-centric manner primary care at the heart of the system, but particularly because it's a natural setting for first encounter. But we had little progress towards that goal, and the focus for the past few decades had been developing versus developed nations. The main difference with the SDGs and with the Astana summit, which we had in 2018, and prior to the UHC declaration, was actually looking at what we needed to do to achieve UHC, and how primary care could contribute towards that. What that meant also in terms of national context, in terms of investment, and also in terms of measurement. So we are discussing intersectoral approaches, we're discussing whole of government and whole of society approaches, we're revisiting the health policies discussions, and we have commitment across political spectrum on equity-based and life course approaches, which is in a way unprecedented. So what is the challenge to assess how to progress towards that? This is, of course, not COVID specific, but very relevant, because theoretically, had we achieved what we set out to achieve 40 years ago with the Alma-Ata Declaration, everybody would have or should have access not only to essential services, but quality essential services by 2000, which was not achieved. So the discussion over the past few years has focused on what is lacking and why are indicators really outdated. Why we don't have the integration we could have to the public health primary care interfacing, which would be particularly meaningful, considering the public health sphere is rather isolated from contact with individuals, and how we could utilize tools as they were coming along. We have had a plethora of digital tools emerging over the past few years, decades really, on how to optimize patients' input and information, including in underdeveloped systems, to utilize e-health solutions. The problems that they are being faced, not only in primary care, but across healthcare systems, on depleted resources, on a lot of information which is not matched or which is very divergent and very difficult to interpret once the setting changes, are quite well known. And the importance of measuring the quality of services, particularly of primary care, has also been debated extensively, and it's now part of the 2018 strategy of the Commission. This is also supplemented by an integrated framework for digitalization, but I will come to that in a minute. So for me and for all, and now according to the UN, for all countries, the primary care is the heart of the healthcare system. It's pumping patients across the system. And it's ideally and optimally increasing their literacy and empowering them to get where they need to get in the system. Many people ask why primary care in particular. Why don't we want to have highly specialized care across the board? It's not only an issue of feasibility, it's an issue of potentially overdiagnosis, or an issue of overprescription, or an issue of medicalizing care, over-medicalizing care. But we all agree that it's better to have one coordinator of the health record for an individual and to build a relationship of trust. And the single richest source that we can have healthcare data from is actually in the electronic health records. In Europe, we say general practice, but we have also family medicine and many other descriptors. So it comes at the primary care practitioner's health record maintenance, where ideally you have a family physician and a team monitoring the health of an individual, of the family, understanding the context and knowing who they're treating. And of course, this is the setting where we, as mentioned, we have the first contact, and where we can start sort of building observations, including for observational research and interventional research. And ideally, what we need to have is an integration of this clinical and research data to discuss system-level decision-making, but also to empower shared decision-making in the person-centered context. So ideally, I think in the previous presentation that was briefly mentioned, and I think many people are very excited about what you can do with the mobile. And indeed, we have seen so many apps coming around, and with the app is connecting and data flowing in. And not only sporadically data of a certain quality, but data of high quality data. We have also seen a willingness of people to commit, share, give their data in the context of COVID-19, but not only, without necessarily being overcautious. It is a trade-off, but people appear to be willing to do it. We have seen that in the past 10 years with wellness applications, but not only. However, I would like to discuss very briefly why it's not as simple as collecting data through a mobile. The infrastructure in some settings, in the QUK, for example, we have had digital records for more than 30 years. In Greece, it was 2012 that was set as a milestone, but it's still emerging. So we have very heterogeneous settings across Europe and, of course, across the globe. But it's not as simple as collecting data through a mobile, because the data that we collect through different applications or through different systems does not necessarily talk to each other and is not interpretable. So the way we get these things to talk is through standards. This is a project in which Greece participated. It was pan-European, and we actually looked on bringing together different clinical trial information models, where you have more controlled environments, if you like, in trials, and see the interoperability. The emphasis at the time for us was diagnostic error, and ensuring we had, beyond standardization and guidelines, generation of information that could contribute to better health at population level. So pulling data through research conducted on primary healthcare in a systematic but regular fashion, not in the case of just a one-off or an acute event or of a single disease, and pulling all of that together and making it become meaningful to inform diagnostic prompts and assess diagnostic error. At the time, the focus was safer clinical practice and, of course, generating a more robust evidence base, and assessing when it's more relevant to look at epidemiological studies and supplementing with RCTs and vice versa. So the project has had 3 cycles, and it's there for anyone that wants to go into it. Showing a little bit more on why this is important, also in terms of prediction. We all hear in the context of COVID-19 the need to have clinical profiles. Many people say we understand it better, but still, if you compare the level of uncertainty in terms of mechanisms to vulnerability, it's very high. We see different predisposing factors, both biological and socioeconomic. And we also see many trials, RCTs, but not only, giving information which is congruent across settings, but we're also seeing some information which is quite disparate and potentially very difficult to interpret and make bigger decisions on what we prescribe, and indeed on what we invest our very meager resources. Because the moment you have 10 people and, I don't know, X amount of money, if you have 1,000 people and same amount of money, the resources become depleted by definition. So you need to make decisions which are very difficult to quantify risk into which. So the aim was to build very rich ontologies to support decision making, and also to look at archetypes and templates for standardization, and also make the interface of how this exchange took place in a manner which was friendly for general practitioners and other primary care and social care practitioners, because they are also involved in coordinated care on the primary care setting, and they're not always very familiar either with trial setup or with electronic standards, or indeed, I mean, we're talking now past few years, we have seen a very radical change, but still it's difficult to get used to new systems. So the models we looked at were trying to bridge also ontologies that were being used at hospitals, and to ensure that we had what we call controlled vocabulary, so describing the same thing with different terms, rather than, for example, say erythema, redness, have terms which were meaningful for all different specialties and general practice, of course, but also that were meaningful potentially to patients. I would like to say that for those of you which may be interested further in what can be achieved, I mean, the ICD has been updated. It's a unified coding system, which is now, the newer version is more updated and focuses more on symptomatology. And this allows us to have, from first encounter and across the system, coding, so to see not only how the patient or the person goes through the system and how symptoms evolve and therapies work, but also to quantify risk, quantify cost, plan ahead. This is becomes effective. It was presented in last year's World Health Assembly and becomes sort of fully operational in 2022. But nevertheless, it is quite amazing because it is a one system, an interoperable system, which brings together many different coding systems of the past. This really would mean that we have one standard API for all kinds of applications. And in terms of coding combination extension codes, these would remain clinically relevant rather than become just descriptors, and would also be possible for us to have more automation and digitization by having output read through machines. And there is indeed a special version for primary care in which symptomatology and what is more relevant for description, for narratives and so on is currently being discussed. So it's a way of catalyzing integration. What is more perhaps relevant in the context of COVID, it was always relevant, but now I think it becomes relevant or actually apparent to people which are even outside the realm of trials or outside the realm of healthcare practice, is translational research and participation, including follow-up, is possible because of this kind of coding and this kind of communication. And this is indeed unprecedented. So across Europe, I do not know if you can see the screen well, but this is the most sort of one of the most famous fairy tale for each country. So we do have great heterogeneity across Europe, and we do have resource limitation. But nevertheless, the challenges that we are seeing in the systems that were very deprived and systems that were very developed in terms of communication were very similar. And I'm mentioning this because I want to make a very quick, small note on communication. Communication has been key, but we've really not looked at it that much. This is what, if you like, compromises encounters. And of course, in the context of uncertainty and new therapies, you have a communication of benefit risk. So you have a communication of something you may not very well yourself know, if you like, if you are a practitioner, or if you are a patient or a citizen, you may have to make a decision for someone else. We saw this in the context of COVID on the basis of very limited information and under pressure. So also need to keep in mind that practitioners are not machines. So we have achieved to some extent, and after 20, 30 years of research, technical interoperability, but we still are lacking sort of semantic and of course cultural interoperability. The most recent, if you like, challenge, which I'm pretty sure all of you have heard, is the GDPR and what that does mean in terms of legislative interoperability and exchanging data sets. So this is a facilitator, if you like, because it pertains to what we have in Europe, not only for healthcare, but across the board intersectorally for the digital single market. And it sets standards. So we do have a broad regulatory framework for collaboration and data collection. And that data collection is continuous, and it informs not only investment in healthcare, but investment across sectors. So it can also inform the impact thereof. And in terms of what that means for citizens, it means they can be more empowered for the personal health data and understanding fragmented structures as well. And there's a lot of work at the moment, even before COVID, taking place on what that means in terms of deciding on which approach you want to take, which encounter you want to have. As I said, this is not interactive, but I'd like you to take a moment to think, when does an encounter become critical, and indeed when the characteristics of an emergency or a crisis. This is a debate that we had in Marseille way before COVID, and also last summer in discussion of migration with the Commission. And how do things change when you have an encounter of 2 or 3 people, or an encounter of many people becoming critical? So in terms of defining a crisis, any situation perceived by an individual as difficult could potentially be a crisis for him or for her, not necessarily for everybody else. And it can be specially recognized at different levels of intensity. And of course, in the term, when we're discussing COVID, when we discuss crisis management, this pertains both to preparedness and response. And I think we heard preventions very briefly in the past. So in terms of exposures, prevention and preparedness are quite tightly knit. Also, crisis could be a decisive turning point in making a decision for a path. There is a difference semantically for emergency, because emergency, in a way, is broader. But I don't want to go into too much detail, but what I want to say is that in the past few years, and although we had this discussion about disease X, we had envisioned in the preparedness and in infectious disease control activities, we had envisioned something different, like superbug from antimicrobial resistance, let us say, not this mild symptom in most population, but really devastating and fatal in other parts of the population, spreading with this very high level of transmissibility across the board. So the discussions were more focused on other things. And suddenly, we had a situation. I mean, this slide is from last summer when we were laughing and saying, of course, these things don't happen anymore. But the fact is we just actually landed in one such situation. So theoretically, we saw that you can do many different things digitally. But in actual fact, when we go into pragmatic and formalized responses, we had migrant waves in Europe, and there we saw that telemedicine, telemonitoring, online translation, many other tools were theoretically available, but practically there were many ethical and clinical and even social problems and challenges. And then, of course, for COVID, we had the infodemic, and we found practitioners really at a loss on how to tackle it. And we had not only individuals, but also many practitioners struggling to understand whether they were doing things right, whether they were coping right. So this is a theme across the board, both for people who are carers, both for any citizen, but also for practitioners. So I'll stand this a little bit on discussing for 2 minutes compassion. We have seen people dying, but we have also seen exhausted systems and practitioners experiencing compassion fatigue. We have previously seen this in different settings, including for the care of migrants and refugees. But for COVID, we saw things which were, let us say, extreme. We have seen suicides, and we have seen exhausted and disappointed people giving up, in sort of breakdown mode. Compassion normally has very rapid onset, and the burnout emerges over time. We also have a post-traumatic stress disorder, and we pretty sure that we will see evidence of that as we go along, even after first, second, or X wave of COVID-19. But learning to recognize when you are suffering from compassion fatigue is a very long story and a very difficult one. So professionals or even people suffering from compassion fatigue normally believe that they become nervous or that they will become impatient, but actually they become depressed or sad or indifferent. So there has been a lot of work on that. And there's also the mindfulness research, which may be of interest. So I'll send some material for that. And what is more important to discuss, and I think I have seen many good messages on that, is on utilizing digital tools to have physical distancing, but not to have social distancing. And I think in that way, we were very privileged because never before we had such tools to allow us to communicate with our dearest and nearest. Of course, I'm discussing very developed nations, but not only. And to be able to have telemonitoring and at a cost approachable, if you like, manner. So the issue that remains unaddressed and not well researched is what happens if self-compassion is not there and the perceived risk changes because somebody is exhausted physically and mentally, and what happens in terms of risk behavior. So how does your behavior to risk and your practice changes? We've seen many people, lockdowns are off, we see many people, although they have digital tools and they can check things, they want to go out and experience physical contact and be amongst people. And we're discussing re-exposure, we're discussing immunity, we're even discussing tourism, which is a very prevalent topic in the Mediterranean. So there is a lot of research work behind that, but I don't want to stay on that. Just want to say, to sum it up, that this is a global problem. And I think this brings us together than divides us. We do have political declaration tools and commitment, and we do have a lot of information being exchanged like never before. We do have a low degree of integration in terms of the tools we already have available. So many things could have been done before, but we see barriers being broken down. So I think it's perhaps, I'm not going to close with a poem. I wish I had one ready, but I will say that it's better to have this now than before because we have more tools available for us than ever before. And the things that people should think about investment and policy making in healthcare and beyond are pretty consistent. Investing in primary care, protecting public health policy making and recommendations in base of the evidence. But more than anything else is back to UHC. So it's the last item on this. You need to protect your workforce and the people because leaving one behind compromises everybody's life. Not only social cohesion, but survival too. And with that, I think I'm on time because we started at 10 past. So with that, I'd like to thank you all for bearing with me.
Thank you so much, Elena. So I've got a few questions for you. Mm-hmm. So do you ever feel like there are too many digital tools and that they can change too quickly? That's the first question.
Yes, there are too many digital tools and they can change very quickly. And this is, I didn't elaborate on it, but this is why we need to have as many possible agile teams and people, particularly practitioners, learning to utilize them. So it's not only that we have many tools, is we do not have guidelines or, if you like, some sort of indication or instruction on what to use, what not to use, and what risk each of every tool represents or may hide.
Thank you. The statement that the ICD-11 works with any software seems impressive. Is this too big a promise?
It's not that it works with any software, it's that it allows systems to crosstalk. So theoretically, if you have an application, you can set an API on it, and I'm saying it very broadly, but there's information in the WHO site, and I will also send some to disseminate. Theoretically, you can extract and make the data meaningful. So it's not like necessarily that you have the systems talking to each other, but it's like you can have somebody translating in between two systems. So it's a coding system. And if it's implemented, because it's not yet fully implemented, yes, we are better off than we ever were before. Or I'm optimistic, but yeah.
Thank you. Why do you think countries struggle with interoperability, and will we ever reach a stage where we can achieve interoperability in Europe or internationally?
Well, interoperability is a difficult word, but it's nothing more than being able to talk the same language as two people. I think historically, because the systems evolve very differently, And for example, for primary care practice, people that wanted to be either very young and optimistic or were very old but very sort of disruptive, they wanted to put a health record in place, and this is 20 years ago, or somebody wanted to develop an app or develop a system. So where there was a willingness or resource or political will to invest in that, it happened. I mean, Estonia went completely digital in 2010, and that has not yet happened in Germany. It's not a question only of resources, it's a question of different factors coming together. But having said that, I think it has been very slow progress on ICT, but it is there. And with that thought, I would also like to say, for whomever is interested, that in the European Federation of Medical Informatics Group, we are reviving a group which has been there for a long time with quite famous people, if you like, the primary care group. So I would like to say that we are restarting that in September, and I'm hoping that many people would like to be there and discuss exactly this kind of thing.
Thank you. Just a few more questions for you. How can we train clinicians in health informatics to better take advantage of digital tools?
I have put it in my slide. I mean, it's the same as for compassion and for everything. It has to start very early. I mean, it's not a question of being taught to use system A or system B. It's more a question of of learning how to self-develop and become agile, and learning how to learn as you go along. So learning was in the past, if you like, more seen, or in the past few decades, as an isolated procedure, but was formalized in early years of training. And then, you did some continuous learning activities here and there. But the world goes very rapidly. So the professional development has to be seen as something continuous. And because we're in public health practitioners speak a different language to primary care practitioners. And other specialists also. So we need to also have things where we all train together. I think that's part of the secret. So for medical informatics, I think we have been too distant from each other. They're very small pockets of activity where people come together. I think this will change. And I also think we have living labs. So I think it doesn't have to be only clinicians or practitioners and medical informatics. It can be citizens. It can even be adolescents. And I think we have the first coding event coming up. I don't know if it's today or tomorrow, from the union on helping your child as a parent to learn to code and so on. So I think the earlier it starts, this way of thinking that we need to keep on learning, the better.
Great, thank you. And one last question. How important is it to prioritize e-record inputting and management during this time with increasing pressures or deficits in workforce numbers?
It's a very difficult question. It depends on your resources and your system. I think it's still very important. I think it's still key. If you do not have high quality information and understanding of your population, you cannot proceed with decision making. So I think we had an opportunity to do just that at the beginning of the year. In some cases, it was looked into. In some cases, it was ignored. But this is neither here nor there. We are where we are at the moment. And really, this, even if there's no second wave, or even if this is still the first wave of COVID-19, it highlights nothing more than what we've already seen with other challenges and crises in the past. The fact that we really need to invest into that and have high quality records and high quality data at population level, sitting and extracting data from EHR. I mean, I will also mention for 10 seconds an example. You're seeing, all of you probably are seeing a lot of discussion on remdesivir, which is a repurposed drug. So it's like having a drug for one thing and using it for another. It's quite common in cancer, but not only. And the information from that comes randomly from off-label use from electronic health records. So the need now is visible to everyone because the discourse has extended to, daily discussion, daily debate. But it's on our TV and it's on our living room. But actually, the problem was always there. And I think there are many people arguing that the CFR for flu is similar, or at least not that different from COVID-19. I don't want to discuss that, which I don't necessarily agree with. But the point is that we have people dying from many different reasons, including, side effects, hospitalizations, which are necessary for diagnosis. So the need is there and we should do it. But that's my subjective view.